So the topic which I'll be speaking is, I think it's maybe a repetition of Dr. Elizabeth, Dr. Shashikala. So, but I'll just go in brief. So, what are the ophthalmic manifestations and assessments in cerebral visual impairment? So basically, we have three stations: the occipital lobe, posterior parietal lobe, and temporal lobe, and that is very important for us to understand. So most of the cases, we do get an MRI, which will be our one of the topic where we'll say how does MRI correlate with our higher visual deficits. So she's again mentioned about testing of visual acuity, color, contrast sensitivity, and visual fields in all children with CVI. And there are instruments to measure these important things for checking the occipital lobe functions. So damage to the occipital lobe will cause poor clarity. There may be inability to perceive colors, and there will be less contrast and visual field deficits. So less contrast is very important to check, especially in children with CVI, because the rehabilitation person will have to be told that the child has a low contrast or how much of the contrast is not there, so that to further plan the rehabilitation session. So station 2 is the posterior parietal lobe. As it's mentioned that there are two streams, the dorsal stream and the ventral stream. The dorsal stream connects the occipital area with the posterior parietal cortex, and so it tells us everything like a where. So you analyze the visual scene and give attention to the object of interest with the posterior parietal cortex lobe. So this is how we get the visual guidance of body movements, and for everything in the development of the child, these things are so important, because if our posterior parietal lobe is damaged, most of the things, our developmental gets hampered. So how do we check it in the OPD is also very important. And they will also have problems in like differentiating things, because they have inability to process multiple visual objects in the surrounding. And that is what a child initially fears, because when they are put with so many objects, and then the fear starts. And this is called as simultaneagnosia. And low visual field impairment is something which we see very common. And most of the parents say that like my child does not see the inferior field and therefore bumps into objects or into any obstacle. So this is because superior optic radiation serving the lower visual fields, they pass through the posterior parietal lobes. So this is affected. And there also is an impaired visual guidance or movement, which is called as optic ataxia. So now you see a child, it's a simple Lia puzzle, which should be informing a part of the armamentarium now, or for a pediatric ophthalmologist. We can't say we cannot have this. So this is a child with right hemiparesis, and he is struggling because of the eye-hand coordination problems, and he's not aware of the directions. And these are problems of children with brain damage, even with mild brain damage. So we should do these tests if we are having a doubt, and find out how much of the cognition problem is there to identify to the rehabilitation expert. And so this is optic ataxia, which is called as impaired visual guidance or movement. It looks simple, which we all, I think, make our child play when our children are small, but it helps us to identify the problem. Then she's already showed you the Lia mailbox, and this is a child who is asked to drop a card through the slot of the Lia mailbox game, and then he would properly tell you about the perception. Oh, it's tilted, the image. It tell you pass the slot correctly to the orientation of the slot by turning the card in the correct position. But if you see the child with CVI, he will not be able to do the simple task. So this things we have made in the OPD with a simple card. We do not need to have big things, because most of the things are expensive. But these simple tests tells us that there is optic ataxia, there is impaired visual guidance to movement, and all these help us in identifying the Lia. So the ventral stream also, it helps us in recognizing. This connects the occipital lobe and the temporal lobe, helps us in recognizing color, shapes, objects. So this has been covered by the previous speaker. So now how do we do the eye examination, and how do we say that this is CVI and not OVI? So because now CVI is a big term covering a range of visual difficulties, ranging from profound visual impairment to low functioning CVI to near normal visual acuity. So you have to correlate, like what we find is that on the if you see the visual examination, you find that the ocular findings not visually explain to you the visual difficulties of the child's or the parents. So once you come to know that okay, this child is 636 and I'm not finding anything which is which is telling me that what is the reason for the 636, why there is suboptimal vision. And then I look at the disc and I see, oh, there is a temporal pallor, and then I investigate further, do an MRI and find out, okay, now there has been an insult to the brain, and now how do I proceed? So this is how you have to pick it up. There may be a latency for visual response. So all these small tips like a visual attention span, difficulty with crowded visual information, light gazing behavior, all these things help us to pick up, of course, a child. So a normal child will be one who at the same age has a squint, but will be able to reach out to objects even though there is a squint. So this is ocular visual impairment, and the child will be able to look and pick up the object. But you see a similar child who is not responding to anything, does not look at the torch or at the light, no contact. See, you have a drum, the child is not at all attentive to it. So then this is a child with CVI. So this is how you will start referring the children and saying that this is not OVI, but this is CVI. Then you'll have a child with, so you may have delayed milestones, like or the child will just light gaze or non-purposeful gaze. So the head holding is not there. So these are all delayed milestones. Maybe the pediatrician itself has not even told the parents that they need to go to an ophthalmologist or to a pediatric ophthalmologist or to an early intervention specialist. So you may have to guide the parents to tell them, okay, now you need to go to an early intervention specialist. This is not normal. So there may be field preferences. So you can do the Leah wand is there. But we use a simple whiteboard, and then we show the objects, a simple puppet toy, and see where the child is preferring to look at. So if there's an inferior field defect, we will write and give to the therapist that okay, there is a field defect maybe in this gaze and left gaze and the right gaze, or in the inferior field. So all this information we need to give to the therapist so that they can work on those fields and they can improve those fields of the child. So there you can also have children like this who I've operated for cataract, but still is not performing well. So then only with the sound the child is responding. So it is very slow in looking at the object. So you have operated, you feel that okay, now I've done, it's 1 month past, fake glasses have been given. Why is not the child responding? Is difficulty in viewing in a complex environment. So what to do? So in that we have to refer. So they also have a color preference. So this we use in rehabilitation. Red and yellow are the most commonly preferred colors because they have the longest wavelengths. So we can use these simple toys, like sometimes you can just use a glaze paper with a red in the torch. You can put a glaze paper red or a yellow and you can stimulate. So children who are not at all fixing and following light, you can tell the parents you start with this if they are staying far away or they're not able to come to a therapist. And that itself stimulates the brain to see. So why it is important to identify the features? Because these visual functions can be easily overcome by simple environmental modification. Dr. Shashikala just showed in her video how by simple techniques they were doing the early intervention therapy. You do not need big instruments or big things. Only the child has to be taught them, because the child is not going to learn by oneself. So we need as parents, as clinicians, to tell them, okay, you show them these toys, you keep on identifying these toys, throw light at the child. So this is how we need to improve their fixation. So now always the parents were after us like, okay, I have brought my child, I don't see any improvement. So how do we check improvement? So this is what is done by the therapist, the early interventions therapist. So they measure the CVI range. So there is like 3 cards, like 0, O, I and D, where the information is through the observation of the child O, and I is information obtained through interview, and the direct information by direct contact with the child. So we can do it, the COVID has taught us that you can even do it through telecommunication. And that's how we measure, like what is the child not able to fix. So that these cards are available on the net. This has been developed by Roman and Lancy, and this you can say, okay, now your child is in range 1 or 2, now the child can be improved to 5, 6 or to 7, 8, and that is how you will, or if it is resolved, you will write R. So you will mention whether there is a right gaze or a left gaze where the child is not following. So there may be wandering moments, the child is sedated, related. So all these things you have to mention in your chart. So this is when the child comes to 7 to 8 range, you feel that okay, the treatment has been successful, which may take 1 year or 2 years. So vision assessment is the same, but we use, I think she's already mentioned about the Leah pedal. Leah pedal is important because most of the neurologists or the or the therapist want us to measure vision. So that is how we measure the vision with the help of the Leah pedal chart, because the child needs to, we are not, like, you cannot, so most of them are like 1 cycle per second or 2 cycles per second or 3 cycles per second. You do not get more. So to improve them further and further, so we need to show them the I'll be just taking another 2 minutes. So the other, this is refraction, which is common as what we, the glasses, what we give it in other normal children. So we need to give glasses to all these children. We can't say that most of the parents say chashma will, their child will not wear the glasses. But it's important that we make the child wear glasses, because that is the important thing, will make them fix and follow light and also help them to improve when we are stimulating the brain. So the therapist always advises, okay, you need to give the glasses. The accommodative status is most important in children, but most of these children, you need to do a dynamic retinoscopy, as mentioned earlier, that we need to check for the lag of accommodation, because these children, everything is nearby. Everything you're wanting to do is nearby. So if the child is not able to see for near, then you have a problem. So if your child is improving, you can see that when you give a +3 or a +4 ad and the child starts focusing at near, it is important to give the ad glasses. So these glasses are very important because 57% of children have these have accommodative lags. The contrast is very important to do. The contrast sensitivity test is also very important. This is our Heidi test. So this helps us that whether there is 5%, 10% loss or 100% loss. And this is important to tell the parent, because in rehabilitation we need to improve the contrast. But maybe the child is not able to see clearly because of the poor contrast. So neuro-ophthalmic manifestations have been covered nicely. And there'll be a talk on strabismus and CVI. I just want to say that we have done a small project in Vrindavan, Mathura, and I hope all of you aim towards these projects. There are many, like we are working with Perkins International. I think CBM is also very keen. We have to sensitize the communities, because these children are just lying down in the communities and waiting for help. None of them are coming to us for help. So we need to identify these children with disabilities. There are a lot of grant funds available. We need to screen and assess them. There are CBR workers who have been trained by CBM and Perkins, and we need to help them by learning, educational and therapy interventions. There are a lot of facilities given by the government. There is training and capacity building for training these community rehabilitation workers. There is also Shiksha Abhiyan and a Samagra Shiksha Abhiyan, which is working on these children, and they're willing to give them disability certificates and also give them they can help them with providing them with all appliances, because that is the problem which comes in these children, that they require appliances. So we need to help them with that. They may not be aware. You need to evaluate the progress and the evaluation of these children. So documentation is important. You need to give them support for aids and appliances, glasses, need-based nutrition support, and school enrollment for inclusive education. So all this we need to complete the loop, and as pediatric ophthalmologists, it is our duty, it is our moral value that we help these children, not only just by surgeries, but also by providing them education and training. I mean, that's very, very important. So you will not believe, these were our numbers which we seen. We seen 368 children which were hidden in Mathura district, and we helped these children. So it is not a small number. We need to help them, and it is my sincere request to all pediatric ophthalmologists, please screen, and there is help. There are a lot of provision provided by the government also. So we can give them at least some support, some interventions, and help them cover, and you can also give them a disability certificate. Thank you.